In this lecture, we will study the left atrium initially. There are many ways to measure the left atrial cavity, each one with their problems and pitfalls. The most common and most accessible is the anteroposterior diameter, taken with an M mode obtained on a parasternal longitudinal X, where the M mode cursor will cross the aorta parallel to its wall and at the location of the valve cusps. If this is observed correctly, one will be able to repeat it in the future for comparison easily and accurate, since it depends on only a straightforward measurement. Even though it is an accurate measurement, to reevaluate a change in dimension of this cavity and to be quite reproducible, you cannot be sure if the cavity is enlarged if its measure is normal. Frequently, the cavity may enlarge in apical basal or lateral medial direction and remain with normal size in the anteroposterior projection, as seen in this location. On an M mode of this region, where we see the parallel aortic walls with distinct cusps opening and closing, it is the place to do the measurement. It is a vertical distance from the posterior aortic wall, starting in the interior of the aorta, to the posterior atrial wall at the moment that the left atrium is largest, at the closing of the aortic valve. The measurement is taken from the internal aortic wall, since it uses the leading edge to leading edge concept. It is essential to check on 2D echo the exact identification of the LA posterior wall, since frequently there will have side lobes in the region of the posterior wall that will mistakenly decrease the left atrial size. One more case, not always easy to recognize if not aware of this possibility. The last measure of 2.7 centimeters is wrong. It is not the posterior left atrial wall, but a side lobe. Occasionally, there will be pulmonary vein entering the left atrial that will falsely increase its size. And all the two possibilities together, the side lobe, the actual LA wall, and the posterior wall of the pulmonary vein. You may question, why not to measure the same LA diameter using 2D long X view instead of the M mode? The reason is the lower frame rate of the 2D echo and the uncertainty if the measurement is performed at the maximal LA size, and it will be not as repeatable as using M mode. The higher limit of this measurement depends on the population study. It may be considered about 4 cm or 4.2 cm. You can also compare its size with the aorta. The aortic and left atrial relation would be abnormal if less than 0.9. I do not like this kind of relationship with only a single structure. It stands to reason that if the aorta is mildly enlarged, as often happens, one will not detect the left atrial enlargement. We can also evaluate the left atrial volume. One of the methods rarely used is that of the ellipsoid, similar to that seen for the volume of the left ventricle. In a parasternal long X, we measure the anteroposterior diameter and the longitudinal diameter. That could also be obtained on an apical 4-chambers view, where we also get the medial lateral width. Using this equation, we would have the volume of the left atrium. No need to keep this by heart. Our echo machine will give you straight from its computer. Another way to evaluate this volume is the area-length method. We do a planimetry of the left atrium using a 4-chambers apical view and 2 chambers that have a similar longest longitudinal length. With these measurements, the computer will use this equation here and it gives you the volume of the left atrium. Here it is, the area, the longitudinal length, and the volume in milliliters. Don't worry if the software that some echo machines use is the same as the one for volume measurements, as part of the ejection fraction of the left ventricle. The concept is the same. When doing the planimetry, you should not enter the pulmonary veins or the left atrial appendage. The method more often used to obtain the left atrial volume, the so-called discs method or the modified Simpson rule. It is also necessary to get the circumference of the left atrium by planimetry and the longitudinal diameter of an apical 4 chambers or even a 2 chambers view. The software will divide the whole left atrium into many discs or cylinders depending on the left atrial diameter. It will calculate the volume of each cylinder, since this volume is just the area of its base times its length. Then it will add the volume of all the cylinders to obtain the left atrial volume. Here it is. The echo machine will give us the length, area, the volume calculated by the area length and by the modified Simpson rule. In this case, it was used one single plane. Another possibility is to use the apical 4 chamber and the 2 chambers and get the mean of the volumes obtained in the 2 view. Notice that in this case, there is about 30% of difference in the volumes from one view to the other. Occasionally, it may be much more than that. My advice is to get the largest value rather than the mean. When using these methods that need a planimetry of the left atrium, it is advisable to decrease the gain of the whole image, since the lateral resolution of the ultrasound diminishes with high gain and is worse at deeper structure as the LA. So, much gain will give you a smaller volume. Notice also that while performing the planimetry, you should start at the annular insertion of the anterior mitral leaflet and finish at the annular insertion of the posterior leaflet. The software will link with a line the end point to the initial. Do not go to the tip of the mitral valve. In other words, the area just below the mitral valve will not be considered. Look here how a high gain will thicken the interatrial septum and the lateral wall of the LA, encroaching into the cavity and decreasing the measured area. The time of the measurement is also important, and hence the frame rate, since a difference in values from one frame to the immediately following one is too big. See that in the first frame at end systole. Look at the movement by the QRS. The LA volume is 98 milliliters. The next frame shows a volume of 141 milliliters. And the next, when the valve starts to open, 65 millimeters. One more advice: avoid foreshortening. Always get longest LA possible. Notice how the very similar method may vary a lot the obtained volumes. There are close to 10% difference in the volume of the LA, even though using the same area but changing the method. The American Society recommends using the biplane modified Simpson rule. The upper limit of normal of the LA volume indexed by the body surface area is 34 milliliters per square meter. For those who enjoy spending 9% of the time doing an exam just measuring, here are the full normal values. Now, what about eyeball? Let's see several examples. A moderate LA enlargement in all planes. LA enlargement with a displacement of the interatrial septum toward the right atrium. An accurate evaluation that the left atrial pressure is higher than 15 millimeters of mercury. Beware, the interatrial septal bulging is only valid for the diagnosis of increased left atrial pressure if the whole septum is bulged. If only a small part of it is displaced, it is probably an aneurysm of the fossa vallis membrane and not high left atrial pressure. Moderate to significant left atrial enlargement. Important left atrial dilatation. Subcostal view of an incredible dilated left atrium. Important left atrial dilation. Significant left atrial dilation. Moderate left atrial dilation. Mild to moderate left atrial dilation. See how our impression may vary from one view to the other. The first one, the parasternal long axis left atrial looks mild to moderate enlarged. In the apical fourth chamber, it seems normal size, and in the subcostal, normal to mild. I would suggest to make up your mind to eyeball if it is dilated or not, then get the measures. Notice that it is easy to recognize degrees of left atrial enlargement with no measures and independent of body surface area if you keep the same structures and cavities with the same disposition within the triangle of the scan. Then the triangle becomes the rule and the guidelines for comparison. In this case, even though the M-mode LA size was normal and the Simpson's was just close to the upper limit, the aspect was suggestive of a mild dilation. Once you have comparing the heart within a variable triangle where the cardiac structures occupy the same space, the scan triangle makes the whole image inside of it the scale. It will be just like you have an anatomic piece of the heart in your hands, and it turns easy to recognize what is dilated or hypertrophy. This eyeball system is much better than this one here, this one where the cutoff is made by measurements, and you must know by heart the values of always check the table in every patient. To make up your mind, you must check all the views. The LA may be normal in a parasternal long axis and questionable in the apical fourth chamber and enlarged in a subcostal view. It happens very often. If you think it is dilated and the simple measurement by M-mode already agrees, that is enough, since for future comparison, this measurement is the most reliable. If it disagrees with the eyeball, get the volumes. If also the volumes differ, then what I do is a report that says, quoted, the measured LA is within normal limits, but the visual aspect of the 2D echo is one of left atrial enlargement, unquote. It is necessary clinical correlation to this affirmation.